Is it rolling? Are there numbers on top? I'm Anthony Pino, critical care nurse. We're doing PALS. This is an update.
I'm Davina Grace. I'm a registered nurse.
And where do you work at?
I work at Presidente Paseo in Albuquerque.
Okay, thank you. So you've completed the pre-course assessment. I also have a copy of your PALS card, which is current. And then I also have you sign a photo release for the purpose of this video. So we've already done videos, but I'm going to go through rhythms and discuss treatments and interact together with her. And then after that, we're going to stop this video and recreate another one. And then we're going to introduce CPR for pediatrics, children and infants, single rescuer, 2 rescuer, AED. This mannequin's brand new, so he's kind of a little hard to push. I haven't broken him in yet. So he's a little clunky. So that's it for right now. I'm going to show you rhythms. I'm going to talk about treatments too. So we have the algorithms here. You have a copy, so do I. The first part of the algorithms begin with the CPR portion for single rescuer, 2 rescuer. Then we have the algorithm for pulseless VTAC and VFib and PE and asystole. It's the same one. Then we have bradycardias here. And then pediatric tachycardia here. So we'll refer to those, and then, so you can use these during your testing, because I don't want you to memorize medication doses. So as we're talking about medications, I have a cheat sheet for you by the Broslow system. Broslow is a system that measures by length. You use length when you don't know the weight. This tape will measure from 3 to 36 kilograms. So it helps you to decide on medications like resuscitative meds like epi, amiodarone, epi-atropine, just a variety of meds, fluid boluses for those age groups. It helps you to select equipment like ET tube sizes, like a laryngoscope blade and handle, and the type of laryngoscope blade like a Miller Macintosh. It'll direct you to the size of the ET tube, angiocast, interosseous. So it has a lot of good information, except I want to say in most cases that the Broslow system here has medications in milligrams instead of how you administer in mils. So this sheet here will give us the mils, but we'll just go through standard doses. But it's more important that in pediatrics you calculate drug dosages, and that your decimal's in the correct spot. Death by decimal is obviously unacceptable. So let's look at some rhythms. And I'll give you symptoms with them or no symptoms. So do your best. And what's this rhythm here?
70 heart rate, sinus rhythm.
So if awake, alert, and talking, that's good. That's part of the pediatric assessment triangle. Pediatric assessment is the first impression. First impression is when you first see them in the 60 seconds. That's the across room approach. And there's a lot to determine in that 60 seconds. So when I'm talking about pediatric assessment triangle, there's a lot to figure. So in pediatric assessment triangle, we go by the appearance of the situation. So in appearance, we're looking at muscle tone.
Okay.
Kicking and fighting is kind of good for now, but if they're flaccid, that's not a good sign. So we go by tickles. I is for interactivity. How are they interacting with the parent? Because your parent for the child is their caregiver, so the child or infant relates to them more as you as the scary medical person with uniforms and stethoscopes and cold hands that freak them out. So that's kind of your assessment of mentation and alert kind of stuff. Next is in tickles is consolability. Are they screaming and crying that you can like, calm down, give them to mommy, give them to daddy, whoever, brother, sister, grandma, grandpa, whoever they interact with best. Look is featuring their eyes, so if they're visually tracking you around, that's a good sign. But if their eyes are like obviously sinking in the back of the head, that's a representation of probably failure of some sort, because these are the key indications of how we will assess and our interventions go. The speech, well, I'm not looking at a speech where they have well-developed language like reciting the Bible or anything like that, but like short, broken word verbiage in a child is usually a sign of respiratory distress. And then the cry, like if they have tear production, they're screaming and crying. They could be dehydrated, but tears is a good sign for right now. The effort of the cry, if it's strong, is good. We have more time. But if the cry becomes more weaning, they're getting weak and lethargic, not a good sign, so our intervention plan has to change. So that's one side of the appearance. So we go on to breathing. Breathing assesses whether they have respiratory distress or failure. So for example, if they have tachypnea, that's a sign of distress. How about retractions?
Respiratory distress.
Yes. How about nasal flaring?
Distress.
How about tachypnea, rapid breathing?
Rapid breathing. Also distress.
How about grunting?
Okay, respiratory distress.
How about head bopping? Where they're very lethargic and head bopping.
Okay.
Distress or failure?
Failure.
Failure, that's correct. Central cyanosis, any cyanosis considered failure, so make those distinguishing characteristics and vital signs. And when we blend in BLS and advanced life support together, or pediatric advanced life support, a child or an infant with a heart rate below 60 beats, with poor perfusion, meaning mottled skin, anything like that, you have to start compressions. So when we get to compressions, it's going to be 30 to 2, meaning 30 compressions in 2 breaths. In all single rescuer scenarios, whether it's adult, child, or infant, the depth of compression on adults and children is the same, at least 2 inches. But when we get to an infant, from a year up to 1 year of age, we're going to be doing 1.5 inches. But it's still 30 to 2 regardless. The rate's still applicable, 100 to 120 compression. Push hard and fast and good recoil. So for example, if this rhythm didn't have a pulse, then what would you call it?
Pulseless.
Yeah, pulseless electrical activity.
Yeah.
So it's on the same algorithm as VFib, so PEA is on this side.
Okay.
So what's most important before meds or IVs? High quality.
High quality compressions.
Yes. And if the rescue is fatiguing, you need the compressor is fatiguing, you need to switch them, which is about every 2 minutes. So the idea with any pulseless arrest rhythms or throughout the algorithms, we go through H's and T's, but we got to start compressions. And then we got to get IV access or interosseous access, put them on a monitor. A rhythm without a pulse is considered PEA. The first drug you administer pulseless patients is?
Epinephrine.
How much epi does it advise you to give?
It's 0.01 milligrams per kilogram.
So, and that repeats every 3 to 5 minutes.
3 to 5
So really there's no endpoint to it in cardiac arrest. So as long as you're resuscitating, you're going to give the epi every 3 to 5 minutes, 0.01 mg per kilogram.
Okay.
H's and T's is hypovolemia treatable?
Hypoxia, hydrogen ion, hypocalcemia, hypoglycemia, hypo and hyperkalemia, hypothermia, tension pneumo.
So let me ask you, since you picked out the H's and T's, how would you treat hypovolemia?
Fluid bolus.
Fluid bolus is for pediatrics is 20 mils per kilogram, and it actually works out the same for adults. However, this is pediatrics. So what kind of fluids would you pick?
Isotonic fluids.
Perfect. So lactated ringers or normal saline. So it is treatable. Hypoxia, is that treatable?
Yes.
Do you want to hyperventilate them?
No.
What's the complication of excessive air in the stomach?
Let's see.
Does it improve, if you're doing CPR, does it impair perfusion or improve it?
It decreases
Cardiac output.
yes.
Okay. And so, how about hypoglycemia? Is that treatable?
Yes, with D25.
Correct. I'll bring the D25 up, but we have a variety of meds over here. We'll pick them as we're entertaining the actual code. So, and so we want to check blood glucose on children often. And then intubate them as soon as possible. And then you can certainly gauge the effectiveness of compressions. So by end-tidal CO2. So if end-tidal CO2 you're observing is at 10, 10, and 10, is that effective compressions?
Effective compression.
What if you saw the number at 5?
To increase the rate
Okay.
of compressions.
Yeah, and the depth perhaps, so they're not effective.
Yeah. Right.
What if you're compressing at 10 and suddenly you see a sudden rise by another waveform?
You've hit Ross.
Yeah. So check for pulse quality, which is usually going to be weak. You're going to need to do fluid boluses. What's the timing on the camera?
10:58 or 10 minutes.
Okay. So tension pneumothorax is more trauma related. You get more information into trauma class. But look for tracheal deviation, diminished breath sounds on perhaps the side the pneumothorax is on. They're going to need decompression in chest tubes. You want to look at electrolytes like hyperkalemia, hypocalcemia, and replace electrolytes within the duration and times that you're supposed to give that. So any organized rhythm without a pulse is PEA. If awake, alert, and talking with good vital signs, non-invasive blood pressure, we're just going to observe and call in pediatricians and appropriate people. So what would this rhythm be? Fast or slow?
This is fast. No, this is within limit on an infant.
But let's just say it's higher
Okay.
for a child.
For a child.
What would you call it? But you're right.
This looks like a sinus tap.
Okay, sinus tach with a pulse, with good perfusion. We treat its underlying causes. So if sinus tach is related to fever, what would be the treatment?
To decrease the fever.
By antipyretic.
Antipyretics.
Sinus tach related to pain.
Analgesics.
Sinus tach related to hypoxia.
Oxygen.
So let's just say I gave them a breathing treatment and they're in sinus tach and I just gave them albuterol. Would you expect their heart rate to get faster?
Yes.
Okay, so that could be a cause. Sinus tach with dehydration fluid, so anxiety, anxiolytics. If there's no pulse with this organized rhythm, it is there for PEA. So let's just say we're observing this sinus tach with the pulse, with good pulse oximetry, and then we hear the alarms ringing on the monitor. Is this rhythm faster or slower?
This is slow.
So I'm going to call for help. I assess. I'm checking a pulse and breathing at the same time. The heart rate is below 60, which is shows 40. With poor perfusion, I'm going to start CPR. So if you go to pediatric bradycardia, what medication would you give? Initially.
Atropine. It's the same as adults. It's epinephrine.
Epinephrine, and what's the dose?
0.01 milligrams per kilo.
Let me turn this alarm off. So you could have given atropine, but that's recommended if the brady is a vagal etiology, perhaps during rapid intubation sequence, or for heart blocks. For the heart blocks, for example, let's just roll with this one. What would you call this one? Are the P waves correlating to the QRSs?
No.
We know it's symptomatic, so we'd
Right.
be doing CPR. We could give atropine, but we need to prepare them for transcutaneous pacing. So can you, let's put one pad on the front. One at a time. Good. Put it more in the center, a little lower. What's the timing?
We are at 15 minutes.
I'm gonna roll them over. So let's just say we rolled them over and that one's stuck. So let's just say we gave the atropine for this heart block. Did it seem to be effective?
No.
So let's get ready to pace them. So the pads are on. So here's your pacer over here.
Okay. I'm gonna turn on the pacer.
And give it a rate of some sort. It's at 70 right now.
Okay. So I'm gonna increase the amps on that.
What's the rate at?
70.
Go up a little bit. Depending on your make and monitor, manufacturer, Zols will let you go higher, but like electronic and life pack don't. So we've got, is it captured electrically?
No.
So keep turning up your milliamps, and I'm going to be correlating perhaps a femoral pulse to see if we have mechanical capture. Do we have electrical capture?
Yes.
They're still doing CPR, but the pulse is still not at a rate of 80, or whatever I have it set at.
So increase the amps.
What's your milliamps at now?
25.
I feel a rate of 80,
Okay.
so we've got mechanical capture.
Okay, so I will increase the amp again.
Perfect. You're doing a great job.
Okay.
So this is temporary till a transvenous pacer is available, and so forth.
Okay.
And this is going to need expert pediatric consultation. And honestly, you would see more of this cardiac element with genetic mutation. Like for example, Down syndrome, because sometimes they're born with incomplete heart formations. So let's just say you're taking care of a kid, a family's brought him into your emergency room. They said he's been vomiting, had diarrhea, and has had fever. He's looking at you in the room, he's fussy, so is that okay for right now? He's
For now.
visually tracking you.
For now.
We hook him up to the monitor, and his pulse oximetry on room air are about 94%. You okay with that?
I'm okay with that.
So we put him on the monitor, and we see fast or slow.
Fast.
And what would you call this?
This would be SVT.
Sure, supraventricular tach would actually appear faster for peds. So he's stable. So look at pediatric tachycardia.
Okay.
It comes after Brady, I think, how I position him.
Okay, got it.
So he's stable.
Okay.
So, for example, if they're stable, do you give medicine right away, or what could you do to slower the heart rate down? That's simple.
Okay, we could do like a bagel maneuver.
So depending on the age, maybe you can have them blow on a syringe if they're cooperative.
Right.
Normally infants will put a cold ice pack to the face. Maybe I would have them blow on the syringe. Hopefully it doesn't have fluid in it. Did the vagal stimulation seem to
No.
work?
No.
So, I don't know what I did with my bras located. So what medicate can you give to maybe break this rhythm?
Okay, adenosine, first dose at 0.1 milligrams per kilogram.
Okay, so he is, we'll just say, I'll go with 10 kilos.
Okay.
So we can use this reference sheet. So it says 1 milligram, but the Broslow tape doesn't tell you how many mils to give.
Okay. So that would be 1 milligram.
But how many mils?
0.3 mils.
Correct. So I want to give it fast and flush it.
Okay.
Typically, it's not a therapeutic med. Through therapeutic med, it's more diagnostic, but kids it can work quite well too. But let's just say you gave the adenosine and you see this.
Okay.
Not unusual because adenosine blocks SA and AV conduction. So, and you check the blood glucose and it's 30 on him.
Okay, so we gave D25.
Sure. And so D25, we could give that. And we're giving fluids regularly. We had to bolus.
NS or lactated ringers.
Yeah, and so if it's 20 mils per kilogram, if they're 10 kilos, then how many mils? 20 times 10.
Is 200.
There you go. If you suspect cardiogenic shock, don't give fluid so rapidly. But otherwise, give it like push and pull system like you have in a measuring device.
Okay.
So pull it out and then push it slowly. Pull and push till you have the volume in your syringe and give it over the duration.
Okay.
So what if his SATs had dropped to 90%?
Okay, I would consider putting oxygen, supplemental oxygen.
Right. And let's just say you're trying to put nasal prongs on. Like if they're I mean, they're not doing so well in decompensating. Like if they're still breathing, a non-rebreather mask. If they're awake, alert, and oriented and don't like things on the nose, maybe you can I see the oxygen? I mean the ambu bag with the end of the oxygen tubing. I'm just showing you that normally you can just get oxygen tubing by itself, not like hooked up to the ambu bag. Hook it up to the flow meter and stick it up, and then they can hold it and get their O2. But obviously if they're decompensating, supplemental O2 is not going to be sufficient. So we're still on tachycardias, and we'll use some of the same elements of fever, dehydration. You started IV, and let's just see, you are observing a sinus tachycardia, but you're starting to notice some ectopy. So you have a regular rhythm. What would those be?
Looks like ST depression.
Let me stop it here. So regular, and then that beat comes in premature. Does it look like that one?
No.
So it's Y, so it's PVC.
Oh, PVC. Okay.
Let's just say they're having more and more PVCs, and they go into this rhythm. What's that rhythm?
Ventricular tachycardia.
Weak and lethargic, altered consciousness. I'm going to hit a code button, or I'm going to call for rapid response.
Okay.
And then we got to get ready to cardiovert them. So you can put the pads on like this, but you can do below the clavicle to the sternal border on the left axillary line. So when you're cardioverting, look to tachycardias when they're unstable. Because remember, if stable, use medicine. If unstable, use Edison.
Okay.
So how much would you cardiovert them with?
I would cardiovert begin at 0.5 to 1 joules per kilogram.
So half a joule per kilogram is the recommended. So if they're 10 kilos, what's half of 10?
5.
Okay, so go ahead and sync. Play with the energy. It's currently at 150.
This is it, right?
Mm-hmm. There you go. We'll go up to 50. Oh, what was it going to be at?
5.
5. There you go. Sorry.
That's okay. Charge.
Is it in sync?
It's in sync.
How do you know?
It's in the R interval.
Perfect. R markers. You're doing beautifully. So go ahead and deplete the shock. I'm going to take the O2 off.
Okay. Clear. We're all clear.
Clear. I'm checking the central pulses. They're still in VTAC with the pulse. So did a half a joule convert them?
Yes, with the pulse.
Well, they had a pulse to begin with.
Okay.
So did it convert them back to
It
a
did.
sinus rhythm?
No, it didn't.
So you're going to have to hit sync again,
Okay.
and then go up to 1 joule per kilogram. Okay. Charge it.
We're clear. Everybody clear?
Clear. And they're back in a regular rhythm. Pediatric consultation. They could give them amiodarone, perhaps lidocaine since it was ventricular. Had it been polymorphic event, it would have been magnesium. But adenosine could have been used to see if it would have terminated the VTAC, but decompensating patients with fast rhythm, regardless of age, need an electrical correction. An electrical correction is usually synchronized cardioversion when they have a pulse. No pulse, we don't have to sync with anything. So if it's pulse is VTAC, pulse is VFib, then you just defibrillate. So let's go back to pediatric bradycardia. But for example, this rhythm, let's just say is sinus tach. The family comes in, there's something wrong with them, and we come into the room and we see that the rhythm has gotten faster or slower.
Slower.
So obviously I would start CPR,
Okay.
and then I'll have you try and ventilate. So I'm going 15 to 2, 3, 4, 5, 6, 7, 8, 9, 10. Pull that out all the way. And it has a pop-off feature, but make sure it's locked.
Is it locked now?
Yeah.
Okay.
So come up to the top of the head, so you're using the EC technique.
Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. When you get the breath.
Every 6 seconds?
But we're doing, because remember we're doing CPR.
Okay.
15 to 2.
15. Okay.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So let's just say we stop and check, is the rhythm fast or slow?
It's fast.
Pulses are stronger, but he's not breathing.
Okay, we'll continue ventilating.
So rescue breathing for pediatrics is 1 breath every 2 to 3 seconds.
Okay. 1 breath every 2 to 3 seconds.
So that's going to average 20 to 30 breaths per minute.
Okay.
Then I would get post lab work, electrolytes, especially blood glucose, chest x-rays perhaps. Okay, so let's go on to pulses, VTAC, and VFib. So get your algorithm out for pulses, VTAC, and VFib.
27 minutes.
And it's still rolling. Okay, thank you.
Okay.
So VFib, let's look at it again. That's VTAC. That's not VFib. I can't see down there. If they had a pulse with that, that would be artifact.
Okay.
But if pulseless, that's VFib. This is considered coarse VFib.
Okay.
Ready? Hit the code, call for help, crash cart. I begin CPR.
Okay.
After I determine that they are pulseless and not breathing for 10 seconds, I'm going to start CPR.
Okay.
So when 2 rescuers come in, how many compressions?
It's 15 to 2.
Okay. And so the pads are on. So what's the shock recommended now?
The shock recommended is 2 joules per kilo.
He's 10 kilos, so how many joules?
20.
So set it at 20. 1, 2, 3, 5, 6, 7, 8, 9, 10, 11, 12.
Charge. Okay. Clear. Everybody
Clear.
clear?
No change. Back to CPR.
Okay.
So it's been 2 minutes. Any change?
No change.
Now it goes up to how many joules per kilogram?
Second is 4 joules per kilo.
So now
Oops. Wait, what's
it's 10 kilos times 4.
40?
Yeah, you may not get 40 on there, so you might have to select 50. Oh, you did get 40.
I'm gonna charge. Clear. Everybody clear?
Clear. IV's been established, or an IO. What do you want to give now?
Okay, I'm gonna give epi at 0.01 milligrams per kilo.
And so how much epi in mils?
Epi is,
I'm tired.
okay, we'll switch compressions.
And so how many mils do I give of epi?
0.01 I said, right?
Yeah, okay, so not much, but. So I stop, any change?
No change.
Now it's time to,
Continue CPR.
and according to the algorithm, do.
Another shot.
I'm tired.
Okay, so we'll switch.
Okay. So we'll stay at that.
Okay, now
Okay.
charge. Clear, everybody clear?
Clear. So we're continuing CPR. I don't know where the ET tube is, but it got buried somewhere. But when we do the test off, I'll show it to you.
Okay.
So we've intubated, good breath sound. So compressions and ventilation's asynchronous now.
Okay.
So we gave epi and shocked. Any change?
No change.
So now what do we do?
Continue CPR.
And what's the next medicine?
The next medicine is amiodarone, 5 milligrams per kilo.
Okay, and then if they're 5, so it'd be
10, be 50.
50 mils. So you'd have to look at your box.
Okay.
So amiodarone here. So you would have to calculate, but basically amiodarone isn't on the sheet. So if you didn't have amiodarone, what else could you have given?
We could also continue to give lidocaine,
Yeah, so how much lidocaine? Because that's on here.
1 milligram.
And we're not getting meds down the ET tube, so we're gonna give 1 mil of, wait, 0.5 mils of lidocaine.
Okay.
So it's been a couple of minutes, they're intubated, good capnography, and then I stopped CPR, they still in defib,
Yes.
so it's time to,
Shock again.
you're right,
Okay.
so you can stick to that.
Okay. Charge. Clear. Everybody
Clear.
clear. Charge.
And let's just say they get an organized rhythm back. Remember, CPR doesn't restart your heart. The purpose of CPR is to keep blood moving, brain and heart. Defibrillation doesn't restart your heart. It's used to correct from that normal rhythm. So if I shock back to a regular rhythm, I still got to do CPR.
Okay.
So let's just say we're doing CPR. I check the blood glucose and it's 20.
Okay. D25.
Then the volume depleted.
Okay. Give isotonic solutions.
And then we reassess, and then the pulse is back, and the end tidal CO2 shows 45, so we have
Very
Ross.
good. Okay.
So there's Ross. He's not waking up, so we're contemplating the targeted temperature management.
Okay.
But we need lab work, specialization, other procedures like CT scan, and then defining the targeted temperature management if it was out of hospital arrest versus in hospital arrest, because they're a little bit different.
Okay.
Okay. So you can stop right there. That's the end of demonstration.